On today's episode of the Brain Health Kitchen podcast,
I decided that I was going to do whatever I could to find the information required to help women in particular have the best nutrition and lifestyle support that they possibly could. And then, of course, realizing that 2/3 of Alzheimer's patients roughly are female, then I was just like that lit a fire. Yeah, I think anytime you are going to change your behavior, what you're eating, how you're exercising, something about sleep, stress management, products that you're going to buy, before you spend money or change your behaviors, especially if it's going to impact your health in some way, really look into the person who is giving the advice. Look up what the letters after their names mean. Maybe look at where they graduated from school. Are they licensed? Are they who they say they are?
Today on the Brain Health Kitchen podcast, we're talking about something that doesn't get nearly enough attention, but probably should. How your heart, your metabolism, and your hormones are shaping your brain health, especially in midlife. My guest is Barbie Boules, a registered dietitian who specializes in women's brain health and Alzheimer's prevention. And in this conversation, we go deep into what women actually need to know, what to test, what matters, what doesn't, and how to think about your risk in a way that's proactive, but not overwhelming. We cover everything from cholesterol and blood sugar to inflammation, genetics, and the menopause transition, and how all of it connects back to your brain. This is one of those episodes where you may want to take notes or listen twice. I am grateful to have two of the most trusted brands in brain health as founding sponsors of this podcast. First, we are proudly supported by NeuroReserve, a brain health nutrition company dedicated to bringing us high-quality, science-backed supplements, including Relevate, a brain-specific blend of omega-3 fatty acids, and Revanta, a pure-grade creatine. In fact, if I had to personally choose just two brain health supplements to take, it would be Relevate and Revanta. Learn more about their commitment to brain health at neuroreserve.com and use code BHKPodcast for 10% off. We are also proudly supported by Better Brain, the world's first brain health and dementia prevention program that's covered by insurance. They provide a brain health panel of over 50 markers, expert coaching, and a personalized action plan. Most people pay nothing out of pocket. Check it out at betterbrain.com/Annie. Hi, everybody. Welcome to this episode of the Brain Health Kitchen podcast. Today, I am joined by Barbie Boules. Barbie, welcome.
Thank you, Annie. I'm so happy to be here. Thank you so much for asking me.
I am so excited to get into what we're going to be talking about today. And, Barbie and I are actually friends in real life, too. We serve on the same board for Mind What Matters. We were just in Los Angeles doing an event together. So it's so good to see you again.
Yes, it's awesome to see you, and I hope I get to see you again soon.
Now, Barbie is a registered dietitian who is focused on women's midlife brain health. I think this is such an interesting niche that you have carved out, and of course, overlaps with everything I'm interested in and have been studying as well. But let's back up a little bit. I would love to hear about, how you studied to become an RD. There are a lot of people who are nutritionists, but that's different than being a registered dietitian, right? Can you explain to us what the difference is?
Sure. So a registered dietitian is a degree that requires several years of accredited clinical training at a university or college that teaches dietetics. It includes, it's not just sort of macros and meal plans, it's organic chemistry and microbiology and human anatomy and medical nutrition therapy, food science, public health nutrition. You're really immersed in all aspects of really the nitty gritties of nutrition for several years. And then you do at least 1,000-hour supervised practice. So that's like an internship. And then you take a national board exam, and we have continuing education requirements to maintain our license. And then, of course, we're licensed in our state. So, and I also carry liability insurance. So there's a level of accountability and oversight and a code of ethics that registered dietitians carry that someone who maybe just calls themselves a nutritionist, which quite frankly anyone can do because it's not a regulated term, that person wouldn't have. So including things like functional nutrition, which sounds fancier, but that's not really that's not a recognized term either. And I also want to caution people, because I'm seeing this more and more on social media, people saying that they're board certified, but not really in anything legitimate and not from an accredited board of any kind. So look deep when you're taking advice from someone. You want to be sure that it's not just their opinion or, based on a couple of books that they may have read, but really they have a deep education and they have accountability if they mess up.
Well, this is so important because there's so much information out there about nutrition,
Right.
especially brain health nutrition,
Hmm.
coming at us from all different directions, from all different, people with different letters behind their names. And
Hmm.
so I think it's really good to know that what an RD really stands for.
Yeah, I think anytime you are going to change your behavior, what you're eating, how you're exercising, something about sleep, stress management, products that you're going to buy, anytime you hear something compelling, before you spend money or change your behaviors, especially if it's going to impact your health in some way, really look into the person who is giving the advice. Look up what the letters after their names mean. Maybe look at where they graduated from school. Are they licensed? Are they who they say they are? Because it's kind of amazing how bold some people are about saying that they have, expertise that they don't really have. And we live in a world where, chiropractors call themselves doctors, and technically they are allowed to do that, but in no way do they have the same training as a medical doctor. So we just need to be cautious about where we're getting our information, especially with social media. Is being
Right, right. So that's why I'm so excited to talk to you because, with brain health nutrition, there's a lot of nuance
Yeah.
and the science is evolving rapidly.
Hmm.
And unless you're immersed in this and have an advanced degree in it, it may not you may not grasp all that nuance. So
Right.
tell me, how did you come to be focused on women's health
Hmm.
first
Hmm.
and also women's brain health and specifically Alzheimer's prevention?
Hmm. So when I went to school for dietetics, it was actually kind of my second career. I went back to school at 27. So I was already a little older and already kind of thinking about women's health in particular. I had read a whole bunch of books on women's health prior to starting school, which is kind of what the impetus. And I noticed when I was in school, there wasn't much distinction between women and men's nutrition, with the exception, of course, of pregnancy and lactation. We didn't talk about menopause at all. And that was interesting to me. And so I decided that I was going to do whatever I could to find the information required to help women in particular, have the best nutrition and lifestyle support that they possibly could. And as I got older, and things started to change for me. And I learned about this thing called perimenopause and menopause and all of the changes that can occur cardiometabolically because of these hormone shifts. That's when I sort of got interested in midlife women and all of the unique facets of that. And that's when I realized that the health of our brain really rests on our cardiometabolic health. These are really important contributors to how well our brain ages and how well it functions in the present. And then, of course, realizing that 2/3 of Alzheimer's patients roughly are female, then I was just like that lit a fire. I wanted to know everything about that. And then, as my professional interests and passion became personal when my own mom was diagnosed with Alzheimer's, which just really, I had already been practicing this, but that just seeing that disease up close as you have it also just really made it everything just sort of crystallized that this is my life's work and this is what I'm supposed to be doing. So that's how it kind of evolved for me.
Oh, it's so interesting how we have such parallel experiences.
Oh.
As a physician, I was one of the few back in the day interested in nutrition and was a big proponent of the Mediterranean dietary pattern for my patients and those going through menopause. But then when my mom was diagnosed with mild cognitive impairment, I did a really deep dive into the nutrition to find out, is there a dietary pattern that could slow progression or even prevent it for, my brothers and me? And so that's when I decided to focus as well, and
Yeah.
I guess I didn't realize how similar our histories are in that regard.
Yeah, and then of course, as we both know, Alzheimer's, the pathology, is actually beginning in midlife for many women. It's not, right before symptoms start appearing. Now is the time. This is the real inflection point. And this is when we can really make change that can, either slow progression, maybe prevent it, just take us in a different direction and definitely help our brains age better.
So let's talk about women and Alzheimer's.
Hmm.
You said that women have 2/3 of all cases of Alzheimer's are female, basically,
Hmm.
which is
Like twice
basically
the risk of men. Yeah.
twice the risk of men. And I know there are a lot of theories bouncing around about this. We don't know exactly for sure. But what are your thoughts on this? Why do you think women are vulnerable to Alzheimer's?
Yeah, it's such a great question, and I cannot wait for this question to be answered with specificity so that we can really head it off at the pass, hopefully. I'm really excited about the Welcome Leaps Care Initiative, cutting Alzheimer's with endocrinology that Dr. Lisa Mosconi, neuroscientist, Dr. Lisa Mosconi is heading up. Their goal is to cut Alzheimer's risk for women in half. And so they are really on it, trying to figure out what about women uniquely makes us uniquely vulnerable. And the hypothesis, obviously, with endocrinology being in the title, is that it has something to do with these hormonal shifts that occur during midlife. And that would make a lot of sense. It has absolutely been observed that there are differences in brain metabolism that accompany the menopause transition, and possibly how the hallmarks of Alzheimer's pathology, amyloid plaques, and tau tangles. Maybe there's a difference in how they accumulate in women. We know that women are more sensitive to the effects of the ApoE4 gene. So there are a lot. And then there are, that there was I can't remember where this article was published. I want to say it was Nature magazine, a really interesting article um, about all of the things that we don't always consider, like the societal impacts and historical factors and racism and sexism and caregiving roles and less opportunity for education, say 20, 30 years ago for women. And access to care and being taken seriously in a medical setting. So I think there's a lot that plays into it. And it's not a question we can answer today. We can just be aware that it's a fact, and that women should be, really, really on top of their brain health and everything that they can possibly do. But I'm looking forward to the answers, just like you are. I know.
Same, same. And you mentioned ApoE4. For our
Mhm.
listeners who may not be familiar with that, that's a gene variant that's very common
Mhm.
and may increase the risk of Alzheimer's. Could you explain to us a little bit more about ApoE4?
Sure. So, the ApoE gene, all of us carry two copies of it. We inherit one copy from each of our parents. And there are three possible alleles that go along with this gene. So there's ApoE2, ApoE3, and ApoE4. And because we each carry two copies, there are six different possibilities. The most common combination is ApoE3 3, which is what I have. It's what the majority of the population has. ApoE2 is relatively rare and seems possibly protective against Alzheimer's disease, and ApoE4 increases risk. And one copy increases risk by about 3 times compared to somebody who does not carry ApoE4. And two copies, so you inherited a copy from each parent, increases your risk by about 12 times. So it is in no way deterministic. There are plenty of people who even carry two copies of ApoE4 who never go on to develop Alzheimer's. And obviously, plenty of people who don't carry ApoE4 do develop Alzheimer's. So it's not a deterministic gene. There are deterministic genes, but that's seen in early Alzheimer's. You'd see it in your family. Um, and that's not what we're talking about. We're talking about ApoE4. So again, even if you carry it, it's not a guarantee that you would develop the disease. And but it is in my opinion, unless it's something that would only make you anxious. Um, I personally think it's a good thing to get tested if you feel like it's something that's going to make you proactive, because there are certain things that we know about ApoE4 carriers. And again, the research is very much ongoing here too. Um, we need potentially more omega-3 fatty acids. We want to pay attention to that. Exercise is super important. Again, ApoE4 seems to impact women more than men. So if you know you're a carrier, there are certain things that, you want to be paying extra special attention to.
Yeah, and I'm sure that part of you're a brain health expert for Better Brain, right?
Yeah.
So when people come to you with they've gotten all their labs done and you have their history, this probably comes up a lot. Should I
Hmm.
get checked for ApoE4 or not? I
Hmm.
know a lot of people are concerned about the psychological impact of knowing,
Hmm.
the fear of that,
Hmm.
stress of it all, the
Right.
implications, especially if
Right.
they end up having two. But as you just said, there's so many things you can do to be proactive. I know there was a trial that looked at this called the REVEAL trial,
Hmm.
the REVEAL trial,
Hmm.
and they showed that the people that ended up finding out were actually they actually turned it into something good. There was a small amount of stress initially,
Hmm.
but then overall it was ended up being a very positive thing for their brain health.
Yeah, and that's what I say to people. If you think it's going to make you proactive and more encouraged to do all of the things that you want to be doing, to reduce your risk, even in the face of ApoE4, then you should test. If you know it's just going to make you anxious and you would double down anyway, then it may or may not be worth it.
So, what do you say to your clients, for example, when you're doing a brain health consultation for Better Brain,
Mhm.
about whether it's worth being tested? What are the pros and cons of being tested for ApoE4?
Yeah, so we know that there are certain things that are more important for ApoE4 carriers, like getting enough omega-3 fatty acids. Exercise is super important. We know that it potentially has a bigger impact on women than men. So if knowing would help you get motivated to double down on these factors, then it's worth knowing. It would make you more proactive about your brain health, knowing that you have this extra risk factor. Because the fact is, we all have risk factors. ApoE4 is just one of them. There are other risk factors as well. So if this is just something where you'd say, okay, this is just an additional risk factor, I know I have it, so I'm going to double down on the things I know I can do, then great, it's probably worth it. If it would only make you anxious and cause you stress and worry and poor sleep and all of that, then it may not be worth it, and just double down anyway.
Yeah, just do all the things anyways.
Exactly.
Like two of the biggest risk factors for Alzheimer's is getting older and being female.
Right.
And
We can't
so,
change
we
that.
could also argue that everyone should be, really checking off these items that we talk about that
Hmm.
we know are impactful for reduction. So let
Hmm.
me back up a minute. When you were talking about your interest in women's health, you mentioned cardiometabolic health.
Hmm.
Now we know what's good for the heart is good for the brain. That's a
Right.
long-standing axiom of brain
Hmm.
health. Can
Hmm.
you break down how cardiometabolic fits into that?
Yeah. So, first, just to explain what we mean by that: blood pressure, lipids, so your LDL cholesterol, HDL cholesterol, and triglycerides. And now also we test ApoB, or apolipoprotein B, your blood sugar, so your insulin sensitivity, your glucose regulation, and then your body composition. So, how much, primarily what we're concerned about is central fat accumulation and visceral fat and ectopic fat accumulation. So, all of those factors play into your cardiometabolic health. And when we think about these factors, we're thinking mostly about our cardiovascular risk, but anything that threatens your cardiovascular health is also going to threaten your brain health. If you look, and that primarily has to do with inflammation, vascular dysfunction, blood flow to the brain, nutrient delivery, oxygen delivery to the brain. If your arteries and blood vessels are hampered by some of these other risk factors, your brain is going to be as well. And if you look at, say, the Lancet Commission report, the most recent one being 2024, where they outline 14 modifiable risk factors for dementia, there are sort of two themes there among all it's sort of, when you just first look at it, it sort of seems very scattered and all over the place. But if you look at it, there are two themes that emerge. And one is protecting your vascular health, and the other is keeping your brain stimulated. So that's really what it all comes down to in terms of modifiable risk factors that we know about. And that's how cardiometabolic health plays in.
Got it. Got it. So part of cardiometabolic health is preventing diabetes,
Yes.
correct?
Yes. Insulin sensitivity, maintaining healthy insulin sensitivity, glucose regulation. Yeah.
So what is the connection between blood sugar stability and the brain?
So when you have unstable blood sugar, even if you don't have chronic insulin resistance or prediabetes or type 2 diabetes, unstable blood sugar. So if let's for example, say you're not eating all day and you're eating a lot at night, or vice versa, or you just have a really um, unpredictable or inconsistent habits around food, or you eat a lot of foods that are really high in refined grains and added sugar, and you don't balance that with proteins and fats. This can cause blood sugar instability, which can, in the moment, affect mood, cognition, and you're going to feel that in your brain function in the moment. Long term, if you have insulin resistance, that can damage blood vessels, that can damage blood flow to the brain, that can cause inflammation. So all of these things together can impact your brain health. It should be made clear, though, that insulin resistance within the brain itself is a hallmark of established Alzheimer's disease. That is not the same thing as type 1 or type 2 diabetes in the body, peripherally. They can impact one another, but you can have Alzheimer's disease, so blood sugar or insulin resistance in the brain, and not have peripheral diabetes or type 2 diabetes. Similarly, you can have type 2 diabetes and not have insulin resistance in the brain. So these are two separate issues. That said, insulin resistance in the body, if it's chronic, can impact brain health.
Got it, got it. And I know some people will call Alzheimer's diabetes type 3.
Hmm.
I'm hearing that fall out of favor, which I'm happy about because I think it's just really simplistic to think of
Yeah.
Alzheimer's that way, but it is an
Yeah.
important pathway to it, an important facet of it, right?
Yeah, I have always thought of that term as just sort of clickbaity. It's just, I mean, it gets attention, and it feels like something that people can sort of easily understand, but it's really reductive. Alzheimer's disease is about far more than just the insulin resistance that can occur in the brain. And the neurologists, especially the preventive neurologists that I'm friends with, talk to, don't really like that term.
Mhm,
Just because it reduces Alzheimer's to something that is just one facet and
mhm.
isn't really the whole disease, if that makes sense.
Yeah, I would agree with that. So if you're a woman listening to this conversation, you might be wondering, do I have glucose instability? Like,
Mhm.
how would I know that? Like, I
Mhm.
go to the doctor once a year and she
Mhm.
checks my fasting blood sugar and
Mhm.
maybe my hemoglobin A1C.
Mhm.
But, like, how would you know that if you've got this brewing years before a diagnosis of prediabetes shows up?
Right. So HbA1c, or hemoglobin A1c, fasting glucose, are how prediabetes and type 2 diabetes are diagnosed. In some cases, you might add a 2-hour oral glucose tolerance test or an OGTT if it's suspected, but the test results are kind of inconsistent. So that's how prediabetes and type 2 diabetes, or type 2 diabetes, I should say, are diagnosed. There are earlier indicators, and one is fasting insulin. If fasting insulin is high, that can happen before HbA1c is elevated and before fasting glucose is elevated, because your pancreas is working overtime and putting out a lot of insulin to cover the excess glucose in your blood. So it's effective. It's effectively, keeping the glucose out of your blood, and that's reflected by your fasting glucose and your HbA1c. But if your fasting insulin is high, that could signal an issue. So can elevated triglycerides, low HDL, especially triglyceride to HDL ratio. So these are things that you might look at in advance of an elevated HbA1c or fasting glucose. And if those things, fasting insulin, low HDL, high triglycerides, if those things are starting to happen, it's time to start paying attention to improving your insulin sensitivity. And
Got
this,
it.
where
Got it.
there's a lot we can do about that. Fortunately, that's entirely reversible in most people.
So if you're listening and you're taking notes, you're going to give us a checklist, right?
Yes.
For women, in terms of working with your healthcare professional,
Mhm,
the tests that are probably already on, your doctor practitioner's list, plus
mhm,
some other ones that are a little bit more nuanced that are particular to the brain, like that
mhm.
fasting insulin may not be offered to everyone.
Yeah, it usually is not. That's usually something you have to ask for, and there is a huge spectrum of experiences that women will have in a medical setting with their physician about getting these tests that are not standard, like fasting insulin. So I have had some clients who can't even get HbA1c, and or
Really?
yeah, or ApoB. And then don't even get me started on ignoring HbA1c of 5.8 or 5.9 for years.
Right, right. We need to talk about that too. I have one
Yeah,
more question. What
yeah,
about continuous glucose monitors or CGMs? A lot
yeah.
of people are using this even if they don't have diabetes. And
Right.
what do you think about that?
Yeah, so it should be known that despite like you wouldn't necessarily know this from all the marketing and the popularity of these devices, but they're not recommended by any expert bodies for non-diabetics or people not living with diabetes. Um, I am not personally an advocate of using them in people without type 2 diabetes or type 1 diabetes. It's, that's a great tool for both. But for both conditions. But I don't really see it that much anymore. It's interesting. In the last 2 years among my clients, it's really kind of fallen out of favor. They're kind of over it. It was like a trend. But for about 4 years, I had a lot of clients that were experimenting with continuous glucose monitors who did not have any diagnosed insulin resistance or prediabetes or type 2 diabetes. And I saw two very distinct scenarios that would happen. On the favorable side, I saw women who didn't realize that a poor night's sleep would increase insulin resistance. Now this is transient. If you start getting a good night's sleep again, it would correct itself. But they would notice this because these are women who would kind of eat the same breakfast every morning, and they would notice that their glucose response was different if they had had a really poor night's sleep, or if they had had alcohol the night before and therefore had a poor night's sleep. They also noticed elevations in glucose during really stressful times during an argument. And that was positive because it helped women prioritize sleep and it helped women prioritize stress management. But I'm like, I could have told you that. And what I saw that I didn't like and that I thought was really harmful was women who were developing disordered eating patterns because they were starting to avoid perfectly healthy foods that might cause a very normal elevation in glucose, and their glucose would return to normal within 2 hours. And this is what we want to see. That's a healthy physiological response. You eat something, you have a normal rise in glucose, it returns your insulin takes care of it, puts it into cells, or you use it through exercise and movement, and then it returns to normal. That's a very healthy thing to see. But because of the marketing around these products, women were terrified to see their glucose rise even a little bit. So they would stop eating carbohydrates, which means stop eating a lot of polyphenols and stopping eating enough fiber and so on. And so that was something I didn't like to see. So in general, I do not recommend them for people who are not living with diabetes and don't really need to be monitoring their glucose on a daily basis.
Got it. Got it. Yeah, I can see it both ways. It can be a tool for learning,
Hmm.
especially maybe in a short-term period. It can be probably really helpful with someone who was just recently diagnosed with prediabetes and they're modifying
Oh,
their
absolutely.
diet.
Yes. I think if
Um,
you've been diagnosed with with glucose dysregulation, I think it's a great tool, a great teaching tool. But if you're just someone who is sort of like a wellness biohacker type person and you just like data, I think it can be a slippery slope. That's
mhm, mhm. Okay, so let's talk about when women should start thinking
yeah.
about their cardiometabolic health and their brain health. What is
So
a good decade of life to start testing for these sorts of things?
Yeah, honestly, the earlier the better. And I'm excited about the new guidelines from the American College of Cardiologists and the American Heart Association that are really the overall picture from these new guidelines is it's really much more about prevention than it is about dealing with disease once it's established. And so I really encourage women to start testing their lipids and their glucose and their HbA1c. And I would even add in homocysteine and high sensitivity C-reactive protein, so hs-CRP, in their 20s. And if everything is normal and looks good and they're generally healthy, like every 5 years up until the age of 40. And then after the age of 40, I think annually is a good idea because we don't really know post 40 when the effects of perimenopause are going to start kicking in, which can change these numbers in a non-beneficial way. So that's what I would say. Around the age of 20, start testing, or 18, whatever, and every 5 years. And then once you get to 40, start testing annually. That would be my recommendation. And then the other thing is testing LP little a, or lipoprotein A, once. Glad to see that in the guidelines too. This is
Finally, right?
yeah,
We both of us have been recommending that for quite a while.
yes. And again, also in addition to just the standard lipid profile, getting ApoB tested, or apolipoprotein B, which is a more sensitive indicator of all the atherogenic particles in your blood, not just LDL cholesterol. And yeah, LP little a, really important to test at least once. And if you're right around the borderline of the threshold that you want to stay under, test it again after menopause, because it can rise post menopause. And right now with LP little a, I should probably say what it is. It's
Yeah, let's talk about let's dive a little bit deeper into the lipid panel
yeah.
and what these individual tests show, what they're important for or not.
Yeah. So a standard lipid panel is LDL cholesterol, HDL cholesterol, and triglycerides. So historically, LDL cholesterol has been referred to as bad cholesterol. HDL cholesterol has been referred to as good cholesterol. It's way more complex than that. And those are kind of terms that really aren't used very much anymore. Um, LDL cholesterol, we now know, is directly causative of atherosclerotic cardiovascular disease. So it narrows arteries, it causes plaque formation, and it can lead to heart attack and stroke. We want to keep LDL cholesterol nice and low, under 100 milligrams per deciliter for people with very low risk, under 70 milligrams per deciliter for people with any additional risk factors or who are concerned about Alzheimer's prevention, and under 55 milligrams per deciliter for people who have had an event, so a heart attack or stroke.
Yeah, in my mind, I
Um,
think of under 70 for brain health,
I do.
and I
I'm
consider
just
having a family history of Alzheimer's as my risk factor
yeah,
for
and
my target LDL.
I 100% agree. And I honestly think that probably the next time these guidelines come out, I think that's probably going to be the upper threshold. But just to stay in alignment with the guidelines, I'm, just saying under 100 for people who are low risk.
Exactly,
But
exactly.
like, for example, I have very high LP little a. So I am somebody who needs to keep her LDL under 70 for sure, no matter what. Um, LP little a is a LDL-like particle, so it is an atherogenic particle, but it's estimated to be 5 to 6 times more atherogenic than LDL itself because it carries this extra little funky, sticky tail that can get more easily lodged in arteries. So it's kind of extra dangerous. And so if it's elevated, we don't have anything to treat it right now. It can't really be impacted by nutrition and lifestyle. Medications are in the pipeline. Hopefully, we will have effective medications that target LP little a specifically by 2027. But right now, what we know is if you have elevated LP little a, you want to keep your LDL and ApoB super low.
So
And
so just to back up, if you have an LP little a that's elevated, it's just sort of a red flag.
Uh-huh.
that you are someone who is at risk for heart disease because
Mhm.
of the way your lipids are,
Mhm.
and that you need to pay more attention to the other things in the lipid profile.
Right. Yes.
And
You
most
just
people aren't really even getting checked for Lp little a. So this is
No.
brand new as of the new American Heart Association guidelines that came out just 2 weeks ago that they're recommending it.
Yeah, and we've known about the effects of and the existence of LP little a for decades, but it was never really tested because it was considered a genetic factor. You can't do anything about it, so whatever, which I think is incredibly unfair. Because, now we realize that, well, okay, what that means is that you need to keep your overall atherogenic particle burden low. And so that's how it's addressed. For example, I take a PCSK9 inhibitor, Repatha, that helps keep my LDL nice and low and lowers my LP little a little bit, not enough to get it under the threshold. But so I'm waiting on the pharmaceuticals that will target LP little a specifically.
Yeah, I think there's just such a good progression in the whole field
I
because
agree.
I know as an OBGYN, a lot of women were customarily not getting checked for lipids until their 40s, kind of after the
Ridiculous.
baby phases were over,
Right.
right? And once you're in your 40s, if you are identified with having elevated LDL, elevated LP little a, you might already have some plaque in your coronary arteries. Like the damage may already be done.
Well, 100%. And I really think that anyone who and I mean cardiovascular disease is a cumulative. It's kind of like, okay, how do I want to say this so that it makes sense? So if you have elevated LDL cholesterol, say, like 120, 130, those are numbers that I see a lot, probably most consistently among midlife women, if it's not being treated. And it usually isn't because until 2018, 130 was the threshold. We have had several years where 100 was the threshold, but a lot of PCPs have not caught up with that number. So 120, 130, 140 is kind of going untreated if a person is otherwise healthy. And that's a shame because plaque is accumulating and probably has been for many, many years. Heart disease and plaque accumulation can begin in your teenage years. So it really is something that should be checked much earlier than your 40s. And don't even get me started on bone mineral density scans waiting until 60.
Oh, yeah, that's a whole other topic.
I
We have
know.
to have another podcast about bone health.
Right.
Um, and I know we've talked about this before, but I am absolutely appalled when I look at some people's lipid panels
Yeah.
and how their LDLs, especially, have been high for years. Like 130, 140, sure, but also even like 180 or 200. And
Hmm.
the advice that some of these women are getting is, well, maybe just cut back on some of the dietary cholesterol,
Lose
like
weight
the
or
cheese,
start
the
at
egg.
yeah,
And
exactly.
this is not the right advice. This is not helping anyone. I don't know why practitioners are not more aggressive about this, but
I
hopefully
think
these
it's
new
because
guidelines will help.
I hope so too. Something else that I hear a lot, and I think this is really important for your audience because I just know it's a really prevalent misconception because a lot of PCPs are still saying it, that if your or if your HDL looks good, don't worry about elevated LDL. We now know, and we've known for some time, that healthy HDL cholesterol does not compensate for elevated LDL cholesterol. It is elevated LDL cholesterol is an independent risk factor for cardiovascular disease, regardless of what your HDL looks like. So that ratio is pretty irrelevant. If you have elevated LDL cholesterol, you need to address it.
Yeah, this is outdated information. And also, there's so much cool science coming out about HDL, the one that
Yes,
we used to call good cholesterol. Now we know that like higher is not better, right? That
right,
there's actually a range.
right. Yeah, anytime I see HDL over like 95 or 100, I'm not necessarily saying it's problematic, but I start to wonder, is that genetic? What else is going on? And over 135, this is HDL all by itself, over 135 milligrams per deciliter has been associated with increased risk. And after menopause, HDL doesn't have the same helpful LDL cholesterol cleanup effects that it had premenopause. So HDL is very complex and not just good cholesterol. That's what I meant when I said it's just way more nuanced, and it's too simplistic to call it good cholesterol. We're
Right, we're
learning a
thinking more
lot.
about function. So after
Yeah.
menopause, HDL is not as helpful in those, cleanup functions.
hmm
And can alcohol increase HDL or decrease it? How does alcohol have an impact on it?
Well, alcohol can definitely raise LDL and ApoB.
Mhm.
It may or may not have an effect on HDL. It can lower it, but its more pronounced effect seems to be on raising LDL.
Mhm,
So
mhm,
not
got
good.
it. Yeah, we can circle back to alcohol in a little bit if you want.
Yeah.
Okay, so we're talking about the lipid panel. We talked about the screening for prediabetes, diabetes, having good, cardio metabolic health as well.
hmm
Can we circle back a little bit to heart disease in women? Because there was a really important paper that just came out of the European Heart Journal. I know
hmm
both you and I were really interested in reading this when it came out. It was just a few months ago, right?
hmm
And it looked at the different conditions that women tend to have during gynecological conditions like endometriosis
hmm
or polycystic ovary, and
hmm
whether it relates to their heart disease risk later in life.
hmm
And some of this information was quite new
hmm
in terms that they had tracked it. Can you just talk to us a little bit about that paper and what you learned about it?
Yeah, I think that I had been hearing about this for a while because I try my hardest to listen to all the preventive cardiologists that I can and what they have to say. So this wasn't 100% new to me, but I think it's really cool that now it's kind of becoming more mainstream knowledge that um, things like gestational diabetes, high blood pressure, preeclampsia during pregnancy, um, PCOS, early menopause, hot flashes, and night sweats. All of these are indicators of increased cardiovascular risk. And for a long time, people just thought, okay, well, you develop diabetes during pregnancy, it's transient, it goes away. You don't have it when you're no longer pregnant. Let's not worry about it. Same thing with high blood pressure that might occur during pregnancy. This is a window into your vascular health. And pregnancy is like sort of a stress test for your cardiovascular health. And so it's something that absolutely should be raised with your physician, whoever they are now, your gynecologist, your cardiologist, your PCP. Now that you're later in life, they should be made aware that you had gestational diabetes or preeclampsia or any um, uh, cardiometabolic or vascular conditions during pregnancy or PCOS or anything else related to um, insulin resistance at any point in your life. Did that make sense?
Right, and migraine headaches too. I mean,
Migraines,
it all
yes.
makes so much sense as an OBGYN when I would see a pregnant woman develop pregnancy-induced hypertension or preeclampsia. I mean, it's a systemic disease,
Yeah.
and, it starts in the blood vessels, in the endothelium, the lining of the blood vessels, and to
Mhm.
think that that just goes away after pregnancy is I mean, that's kind of what we used to think. You just get
Right,
this, and then delivery is the cure.
right,
Those babies got delivered.
right.
And now that we look back on it, it's a very important thing to bring up to your doctor with when
Yeah.
you're at midlife, or even if you had, like I, for example, when I did my gestational diabetes testing when I was pregnant,
Mhm.
I had a 1 out of 4 abnormal. And so I always remember that I do have this little small tendency. It was a stress test on my metabolic health, right?
Yeah. Yeah,
And I
that
have
I
the
mean, again,
tendency.
yeah, that is how pregnancy should be perceived by women. It is a stress test,
Mhm.
basically. And I mean, we don't want to put any additional stress on pregnancy, but it should be what happens to your body and how your body reacts, whether you retain a lot of fluid or develop hypertension or gestational diabetes. It should be paid attention to. And
Yeah.
again, I kind of glossed over it, but I'm always really on top of telling women that if you have frequent and severe hot flashes and night sweats, you need to let your doctor know because that also is an indicator of cardiovascular risk.
Yeah, we no longer think of hot flashes and night sweats as innocuous, annoying symptoms. We think of them as red flags for,
Right.
heart disease risk,
Hmm.
white matter lesions in the brain later,
Hmm.
which brings us back to perimenopause.
Yeah.
So the lipids change, this lipid profile, the LDL, the HDL, maybe ApoB, it
Hmm.
changes over the course of a woman's life.
Hmm.
And during perimenopause, when there are a lot of hormonal fluctuations,
Hmm.
estrogen's going up and down, progesterone's going up and down, how does this affect lipids? What are you seeing in your clients in terms of their
Oh,
lipid panels across perimenopause?
yeah, my clients and myself. That with sort of the tail, and it can happen earlier, like earlier in perimenopause when those hormonal shifts begin. Estrogen is erratic, progesterone starts to decline. And I personally also think that it's the hormonal shifts, yes, for sure. We know that, but it's also the behavior change that can influence. Like maybe we are not sleeping as well. Maybe we don't have the energy to exercise. Maybe we are craving certain foods that don't align with awesome metabolic health. I think there's a lot that happens during the menopause transition that can impact our cardiometabolic health and our blood work, like our lipids and our insulin sensitivity. But we do know that changes in estrogen do uh, kind of downregulate hepatic clearance of LDL cholesterol. So that's one of the reasons that it rises. And so ApoB is going to rise along with LDL cholesterol. Triglycerides tend to increase, HDL might decline, blood pressure might increase, insulin sensitivity may worsen or just come out of nowhere. And that can happen because of changes in glucose regulation, but also because of an increase in abdominal fat. Any new fat that we gain is going to fit as estrogen declines. Any new fat that we gain is going to favor the abdomen. And some of that can be visceral fat, some of that can be liver fat, so ectopic fat, and that can increase insulin resistance. So all of these funky changes are happening that can change our cardiometabolic health picture. And that's part of the reason that I say women should start getting tested for these basic labs annually. And one more thing I want to say, because blood pressure, and I know you agree with me on this, blood pressure is so incredibly crucial and a little bit undervalued, I feel like, especially in women. Um, I think every woman over 40 should have a home blood pressure cuff. And even if she hasn't been diagnosed with high blood pressure, and just take it, I don't know, maybe once a month under different conditions. Because once a year in your physician's office, especially when you might be rushed or a little stressed or whatever, that's not a great picture of what your blood pressure is doing. So I think having a home blood pressure cuff is also a good idea. But yeah, just your lipids and your glucose regulation and your body composition are going to change in midlife. Um, the lipids and the glucose regulation largely due to the changes in estrogen, but body composition is a much longer process, but we really start to feel it in midlife.
So perimenopause could be looked at as yet another stress test
Yeah.
where the fluctuating estrogen leads to like inability to use glucose in the brain,
Hmm.
that bioenergetic crisis that's been described, like
Hmm.
leading to brain fog, but also these, that your LDL can creep up, your blood sugar can creep up, your hemoglobin A1C can creep up, and you
Hmm.
can start depositing visceral fat. Now, a woman who's perimenopausal, who's noticing weight gain, this is a very common thing.
Yeah.
How does one know if that's visceral fat
Hmm.
or some other kind of fat? Because we know visceral fat is different and it has more implications on health, right?
Yeah. Yeah. Visceral fat is different from subcutaneous fat. Subcutaneous fat is the type of fat that sits just under the skin. It's what we can pinch and jiggles and what we can really see. Visceral fat is deep abdominal fat. It hides behind the abdominal muscles and surrounds organs. And then there's ectopic fat, which invades organs. So that can invade your liver, it can invade your muscles, it can invade your heart, it can invade your pancreas. Um, but the best way to tell if you don't want to spend any money about to determine whether or not your visceral fat is increasing is a waist to hip ratio. So you take a soft tape measure, you measure belly button to belly button, in a circumference, and then you measure your hips, and then you divide waist by hips. And we want to be under like 0.8. And anything in excess of that might mean that you are developing excess visceral fat. A little bit is normal. We want it like under a pound, ideally under a half a pound. The other way to look at it is a body composition DEXA scan. And the numbers are not perfect with a body composition DEXA scan, but it can give you a general idea of your lean mass, your skeletal muscle mass, your subcutaneous fat, and how much you have in what different areas of your body, and then your visceral fat. So and that's around $100. Not to be confused with a bone mineral density DEXA scan that only looks at bone mineral density used to diagnose osteopenia or osteoporosis. So, so those are the two ways to look
Got
at
it. So if you're concerned about that, and your doctor pulls out a tape measure at your annual appointment, that's a really smart metric, kind of like
Mhm.
blood pressure, for your doctor, your nurse practitioner use, because it doesn't cost anything just to keep track of that
Mhm.
hip waist ratio,
Mhm.
right?
Yep.
Or you can do a DEXA scan, not the same one as a bone mineral density scan, but a
Mhm.
DEXA scan for body composition. So if a
Right.
woman has determined that she's starting to pile on some visceral fat,
Mhm.
what should she do about it? How do you combat this? How do you reverse it?
Okay, so the good news is it can be reversed. It requires a little effort, more effort than maybe we've put in the past. Um, One of the most effective methods for reducing visceral fat is cardiovascular activity. So whether it's moderate intensity or high intensity, cardiovascular activity appears to be sort of top tier for reducing visceral fat. Building muscle, also crucially important for so many reasons metabolically. I mean, it really is an endocrine organ, and it's what's going to keep us healthy and increase our longevity and keep us independent and even improve brain health over time. I mean, it's like really the number one thing we should be doing is thinking about improving our muscle mass. So strength training. In terms of nutrition, um, foods that tend to encourage more visceral fat are alcohol, refined grains, added sugar, um, saturated fats. It's not as direct as that, but these are foods that if that's making up most of our diet, we may be accumulating more visceral fat than if we're eating foods that are less refined, more whole, high in fiber, high in unsaturated fat, so mono and polyunsaturated fats. um yeah, so I just kind of, it's all the kind of gold standard low hanging fruit stuff that we know about: exercise and eating more whole foods that are rich in nutrients, and providing a lot of protein and fiber. And I mean, visceral fat is still fat, so it's going to require a calorie deficit to lose it. And we can't really distinguish in the fat loss process between visceral fat and subcutaneous fat. So we're probably going to lose both, which may or may not be, an undesirable thing. But a calorie deficit is often required. And that can be done sustainably if we are patient and we create a plan that really works for us and that is filled with really satisfying foods and hopefully combined with exercise as well.
Mhm, mhm. So it sounds like there's really no perimenopausal diet, but if you think about eating for your brain health and you
Hmm.
institute that, like, early in life,
Hmm.
these are the types of, food groups you're talking about,
Hmm.
like largely plant-based, low in saturated fat, lots of fiber,
Hmm.
good amount of protein, and getting
Right.
on that sort of a eating program before perimenopause even hits is
Yeah, I mean,
optimal.
right. What I always say is if you're eating for the health of your brain, you're taking care of everything. I mean, if you're focused on what we know to be the best foods and nutrients for brain health, you're taking care of your cardiometabolic health. You're taking care of your visceral fat. You're taking care of your muscle mass. You're taking care of your energy. So eating for brain health is, I feel like, really the way to go.
Yeah, and it also sounds like it makes a woman especially more metabolically resilient when
Hmm.
she hits these stages of life where, the stress test is coming
Right.
and she may be doing all the same things in terms of her nutrition and exercise and things still change. I want to back up a little bit. At the beginning of our conversation, you talked about some inflammatory markers
Mhm.
like high sensitivity C-reactive protein and homocysteine. Now, how
Hmm.
does this fit into your plan of assessing the cardiometabolic health of a perimenopausal woman?
Right. So high sensitivity C-reactive protein or hs-CRP is usually how it shows up on, a panel, a blood work panel. It's a marker of inflammation, and it can refer to all kinds of inflammation in the body. So it's not necessarily related to cardiovascular risk. That's why it needs to be taken in context. If it's super high, it can, you never want to, let's just put it this way. You never want to take have your high sensitivity C reactive protein measured if you have the flu, for example, because it could be elevated just because of that. But if everything else looks good, high sensitivity C reactive protein can be an indication of inflammation that relates to cardiovascular risk. And I usually see it in conjunction with lipids that are out of whack. So high LDL cholesterol, high ApoB, low HDL, high triglycerides. It usually correlates with that. It's not in and of itself diagnostic of anything necessarily, but it's an indication that those markers are starting to matter and increase inflammation in the body, if that makes sense.
That makes sense.
Um,
And then what
and
about
then
homocysteine?
homocysteine is also a marker of inflammation. And the most typical cause of homocysteine being elevated is a deficiency in one of three B vitamins. So the most common is B12, then folate. No, sorry. I think the most common is actually folate in the United States. And then there's B12 and then B6 too. Less common, but also can elevate homocysteine. So what we would want to do in that case is start taking a methylated B complex, and that usually takes care of the problem. There are other potential causes for elevated homocysteine, but typically it's deficiency of one of these three B vitamins.
Got it.
And
So someone could
B12 is
be
so
eating
important.
leafy greens like crazy. You could be someone who eats a salad every single day,
Right.
like me. And
Uh-huh.
then I found out when I did the Better Brain program that my folate was really low. And of course,
Hmm.
folate is a B vitamin in
That surprises me.
foliage. I was really surprised. It hadn't shown up before.
Uh-huh.
And with a low folate, you think, B vitamin deficiency, but also it is a marker for inflammation
Yeah.
on the homocysteine level. So that's why
Mhm.
homocysteine is one of those inflammatory markers, particularly important for brain and heart health, right?
Yes, and all three of those B vitamins, B12, folate, and B6, are crucial for brain health. So yeah, that's why I throw homocysteine in there as something I like to know, how a client is doing there, because it's one of the things that if it's a B12 deficiency, it's easy to correct. Same thing with vitamin D.
Yeah, vitamin D also. So we should probably talk a little bit about supplementation since we're talking
Sure.
about vitamins already.
Mhm.
What is your approach to supplementation? We know B vitamins are critical.
Yeah.
Not very sexy, not very, like, interesting to, like, maybe the layperson, but if you talk
Right.
to a neurologist, like, B vitamins are their favorite vitamin, right?
Yeah, I mean, one of the first things that a neurologist or hopefully a PCP would test if you're having cognitive issues is a B12 level, because it's definitely, if it's low, tingling in the extremities, cognitive issues, lots of neurological issues can happen with B12 deficiency. So, super important. I am, as you know, I know you've heard me say this. I'm very conservative when it comes to supplementation. I am looking for either a gap that I can clearly see in someone's nutrition, their overall diet, or I know that they have a diagnosed deficiency or insufficiency of B12 or vitamin D or iron. Um, the supplements that I think are relatively safe and relatively reasonable for most midlife women, because a lot of us, even if, and maybe even especially if we are eating a plant-forward diet, we might be missing out on B complex, because B12, we're probably not getting a lot of B12.
Because you get
Vitamin
that
D,
from animal products mostly.
right,
Mhm.
exactly. Um, uh, Vitamin D, D3, and omega-3 fatty acids, is unless you're eating fatty fish, 3-4 times a week. I know some people say 2 to 3, but honestly, when you really look at the numbers and the like how much omega-3 each EPA and DHA fish contains, if we really want to be getting 1 to 2 grams of EPA and DHA combined a day, we need to be eating fatty fish like 3 to 4 times a week if we're having like a 4-ounce portion. So omega-3 fatty acids. And then magnesium glycinate, I have just seen very helpful for women, especially in midlife, who may be starting to have sleep issues or just anxiety issues. And so those are the 4 that are sort of my go-tos. I don't necessarily recommend them across the board, but those would be the 4 like top picks for me. And then if a woman is strength training, I also recommend creatine,
Mhm.
like 3 to 5 grams a day. And I know that there are some potential cognitive benefits in, or like it seems like there might be some potential cognitive benefits, especially in a brain that's compromised, like depression or sleep deprivation or jet lag and things like that. But again, I don't necessarily recommend creatine across the board. But those are the ones that I generally look to, unless somebody's got some like iron deficiency or something else that we need to work with.
And it's good to know that, the ones that are in your must-have,
Mhm.
must-consider supplement range are things you can test in blood work, but a woman might need to ask for this, right?
Yes,
Most women will
and
be getting a serum vitamin D level at their checkup, but they may not be getting folate and B12. They may
right.
not be getting an iron, which is really important.
And that's a really important point too. Thanks for saying that, because if you are supplementing vitamin D, B12, iron, omega-3 fatty acids, or DEPA and DHA, these are actually things, it's not common at all, but these are things that can become toxic at super high levels. So if you are supplementing, you want to be sure that you're not exceeding levels that are actually optimal. And you want to be sure that what you're taking, you're absorbing and it's working. I've had lots of clients over the years that have had B12 injections and their B12 levels get way too high. I've had clients that were taking 10,000 IUs of vitamin D a day and their vitamin D levels get way too high. So it's, you do want to be testing to be sure your levels aren't exceeding
It's
what's
so
healthy.
smart and so easy to do, and you can
Yeah,
test an
and not
omega-3
expensive.
index too to see if you need more omega-3s.
Yeah.
That's a really simple test to do as well. I
Mhm.
recently crunched the numbers on the omega-3 content of fish and seafood as well, and yeah, like, I mean, the MIND diet, they say 2 or more servings a week. It's really not enough if
It's
you're
not.
relying on that for your DHA and EPA.
Right.
But okay. Okay. So we've covered supplements. Let's go back to the heart a little bit.
Yeah.
When does a woman know she needs to see a cardiologist? Would she
Oh.
go if her LDL was a little bit elevated? If her primary doctor was recommending her go on some sort of medication like a statin? Or should
Mhm.
she just go if she can get in to see a preventive cardiologist just to get a plan for her heart health later in life?
So, because heart disease, thank you so much for this question. Because heart disease, cardiovascular disease is still our number one killer in most parts of the world, of women and men. I I know that this is not accessible or affordable to every woman. If it is for you, I personally believe that a woman 45 and over should see a cardiologist. Your heart is, is everything. And it is your biggest risk factor for illness and death. And speaking to a specialist who really can look at you, your blood work, your overall lifestyle, and create a plan for you that is going to be appropriate, I just think is wise. If that's not accessible and affordable to you, seeing a cardiologist, if you have stubborn elevated LDL cholesterol and ApoB, And it's just not coming down with lifestyle. And your PCP, for whatever reason, does not want to prescribe lipid lowering therapies. I see this all of the time. LDL cholesterol, doesn't even want to test ApoB, doesn't even want to test LP little a. LDL has been in the 120s, 130s, 140s for 5 years, and they still don't want to prescribe statins. If that is you, either find a different PCP who is more sensitive to cardiovascular issues or find a cardiologist. If you have additional risk factors for cardiovascular disease, like it runs in your family, you have elevated LP little a, you have type 2 diabetes, or diabetes, I should say. You've had gestational diabetes, you have high blood pressure. All of these are reasons to see a specialist, a cardiologist, in my opinion.
And when does a woman, when should a woman consider getting a calcium coronary artery score?
Yeah. So the new guidelines are actually really favorable about them. Here's the thing about a coronary artery calcium score, CAC score, a CAC score. They're called, all of these different things. It is essentially a scan of your heart. It only shows calcified plaque. It does not show soft plaque. So it's not a perfect test. And it's recommended if you have elevated LDL cholesterol and have had for a while, if you have elevated LP little a, if you have a history of cardiovascular disease in your family, just to see if you have calcified plaque. It's important to understand that if your score is not 0, even if it's like 1 to 10. I mean, there are people with scores in the hundreds or thousands, but even if it's very low, that is heart disease. That is calcified plaque. So heart disease has begun. That is extra data for your physician to consider when trying to create a plan for you. That in preventive cardiologist opinion, that's automatic reason for statins or other lipid lowering therapies. It's important to understand about a coronary artery calcium score. It does not show soft plaque. So oftentimes people will leave one of these tests with a score of 0 and think, oh, my arteries are perfectly clear. That's not what it means. Soft plaque could still exist, especially if you've had elevated LDL cholesterol or ApoB for a while, or you have elevated LP little a. And in that case, what you really want is a coronary CT angiography. So that shows soft and calcified plaque. So if you have a score of 0, it's almost like it doesn't tell you that much. If you have a score of 1 or above, it tells you need therapy. Does that make sense?
Yeah, that makes sense a lot. I know that you do such a good job talking on your platforms like on Instagram and in your Substack about forming an alliance with your healthcare provider
Yeah.
and getting the care you need without, in a positive way,
Mhm.
right? And
Mhm.
this is one of those things, right? Like when I go to the doctor and I'm a doctor, I
Mhm.
have to insist on getting an ApoB and LP little a. I
Yeah.
have to insist on having a homocysteine. I
Mhm.
had to fight to get a calcium artery score test. I
Mhm.
had to fight to get a cardiology consult
Mhm.
because it's a little bit out of the norm. It's more
Yeah.
proactive than what a lot of medical practices,
Yeah.
do. But
Yeah.
but still, and I think you've written some things on your Substack about, like, really specific ways to do that too, which were brilliant, and we'll have to link some of those articles in our show
Yeah.
notes.
Yeah. Definitely.
But you have to be, number 1, you have to be informed, right? And
Yeah.
then you have to be a little bit insistent and very protective of your health.
Yeah. I think that, I really encourage women to look at the relationship they have with their healthcare providers, professionals, whether it's just your PCP or your PCP and your OBGYN, or if you have other specialties, endocrinologist, rheumatologist, cardiologist, therapist, whatever you have. It's a partnership and you have some responsibility in that relationship too. And that means doing a little homework, knowing what your numbers mean, having records of your numbers so that if you decide to change doctors or whatever you're doing, or you're seeing a new specialist, you can bring your records with you. I think it's really important to take ownership and be accountable to yourself with your health history. And so I really encourage women to understand what their numbers mean, and to look at your relationship with your physician again like a partnership. They actually work for you. You're hiring them, you're paying them, but it should be a partnership. And I fear that not enough women see it that way, and as a result, we get substandard care.
Exactly, exactly. And under treatment, as we
Yeah.
were talking about these cardiovascular risk factors, not
Mm-hmm.
to mention brain health, the whole discussion of brain health, which is
Mm-hmm.
so, so important for women. So
Mm-hmm.
I love the clear plan that you lay out. You have so many great references and graphics on your Instagram. Tell us your Instagram again.
The cognition dietitian.
Yeah. So if you go to Barbie's Instagram and scroll through her feed, you will find so many resources that you can, take a screenshot. These can be checklists of blood tests you need, of target levels, and then you developed a whole library of guides along the same lines on
Mm-hmm.
your Substack. And
Yeah.
your Substack is called
The
the
synapse.
Synapse. Right. So I would definitely recommend that you check those out. And you're going to be sharing with us a guide for cardiometabolic health. Is that from the Substack?
Yeah, and the partnering with your provider too. We could throw that one in there also,
Oh,
because
that's a great idea.
I think that would be really relevant to the conversation that we've had. So yeah,
That's a great idea. Well, I have learned so much. I always learn so much when I talk to you. I always get more nuance on the topic than I had
I'm all
realized.
about the nuance. Yeah.
All about the nuance. So
Mm.
we just have a couple minutes left.
Yeah,
I just want to ask you, maybe on a personal level,
yeah.
how do you approach this stage of life? Like, what is your go-to exercise when things get really busy and crazy?
So walking is so important to me, always has been. It used to be a form of transportation to me, like all through high school, all through college, and all through like early adulthood. Less so now, but I have to walk. It honestly now it's more for my mental health, and I try to walk an hour in the morning and an hour in the evening. I know that's really not doable for most people, but like I prioritize that because it's more for my mental health than anything else. And I try to strength train, as a regular routine every morning, but there are times when my schedule just doesn't permit it. So I have this habit that like I'll do like 25 squats, 25 push-ups, and like grab some weights for like 2 minutes every time I pee.
Really? Oh my gosh, I love that.
So like if I don't have time to like really do my full like half hour in the morning, I'll try to do that throughout the day.
That is fantastic. We were just speaking with Tommy Wood recently on
Uh-huh.
the podcast, and he has in his new book a whole pantry of exercise snacks.
Oh, I love that.
But
Exercise snacks. That's what it
and that's
is.
exactly what you're doing. He does squats as well, and,
Yeah.
I love
I
that.
just habit stack it. So if you wanna call peeing a habit, like that's what but it's like it's a reminder. You know what I mean?
Yeah. No, I love it. I love it. Everybody pees. Um, okay, and when you're walking, are you listening to a podcast? Are you going for silence? Are you calling a friend?
I have 3 different things. Sometimes I'll listen to a podcast, sometimes I'll listen to music. If I'm not feeling it, if I don't want to go, I will listen to music that pumps me up. I also um just window into me. I sometimes will wear my AirPods and pretend I'm talking on the phone, but I'm really talking to myself.
Oh.
Like if I need to like get it out and like have a conversation, like work out a problem or whatever, I don't want to look nutty walking down the street talking to myself. So I put my earpods in and I pretend I'm having a conversation on the phone.
Oh my gosh, I love that so much. Positive
Yeah.
self-talk or
Yeah,
just
because
working through something.
I think better when I'm moving. I'm one of those people.
Yeah.
So, and I have a lot of like I pace when I'm on the phone. I use my hands a lot. I'm just constantly moving around, and so I think better when I'm moving, and so that's what I do. I take myself on a walk, and I have a conversation with myself, but I have my earpods AirPods in so people
I
don't think I'm
love it
talking.
that you take yourself on a walk and you have a conversation with yourself.
Yeah.
Now that is a brain break.
Yeah.
That
Yeah.
is a
It's
true
very
brain break.
effective. Very, very effective.
Okay. All right. Before you go, I would love to know, what do you have in store this year? What is it that you're excited about? What's going on in Barbie's life?
Oh, that's such a nice question. Hopefully some travel. Honestly, I have, spent the last few years really just being almost too serious and spending most of my time deep into research and just being really overly sciencey and just I want this year to be more about self-exploration. So I've got a pile of the books this high that are more about personal stories, fiction. Just I want to reread some of my favorites from 10 years ago. I just want to like find more joy, more whimsy.
I
Is
love that. That's
on
such a
my
great goal. And you're going to come on one of my brain health retreats to Italy one of
I
these days, right?
absolutely want to. Yes, 100%. This year is about having a little fun. I'm not going to lie.
Oh, I love it because you do work very hard. And I read everything you write, everything
Oh,
on Substack, everything on Instagram. Everything is so professional and cutting edge. And it's exactly the type of information that women need to have. And so you're an incredible wealth of information and you do so much of it for free. So
that's
much of it you just give away on your Instagram for everyone so that everyone's perimenopausal IQ is just raising just by following you. So thank
That's
you for all
cool.
of that.
Oh,
Thank you
that's
for
so
all
nice
of that work.
from you, Annie, because you know how much I respect you and I value you and I feel exactly the same about you. So thank you.
And maybe we'll get to cook together again this year sometime.
Oh
We were
my
at
God, I'd love
Rancho
it.
Puerto together last year.
I
That
would
was
love
really
it.
fun.
Yes.
Okay, well, I'm going to let you go because I don't want to have you sitting still any longer than you have to. And just tell us again where to find you.
Yeah. So on Instagram, the cognition dietitian. On Substack, I write the synapse. And I also have a website, barbieboules.com, where you can reach out to me if you'd like.
And you're available for speaking engagements,
Yeah.
correct?
Hmm. Yep.
All right. All right. And you also consult as a brain health expert on Better Brain.
That's right. I coach once a week for Better Brain. Yes.
Fantastic. Well,
Yes.
thank you, Barbie. Thank you for all you do. Thank you for all your hard work. I'm just
Thank you,
so
Annie.
delighted to know you and call you a friend. And thank you
Me
for taking
too.
the time today.
Thank you.
And now it's time for Annie and Jenny's review and do. Hi, Jenny.
Hi there, Annie.
I'm joined by my co host and producer, Jenny Schilling. And Jenny, what stood out to you from this conversation with Barbie?
This conversation really brought together something that can feel confusing, that brain health isn't separate from the rest of the body. It's deeply connected to your cardio-metabolic health. And one of the biggest takeaways is that midlife is not too early. It's actually the critical window. Alzheimer's risk doesn't start when symptoms appear, it starts decades earlier. And for women, that overlaps with perimenopause, when we see shifts in cholesterol, blood sugar, body composition, and inflammation. We talked about how factors like elevated LDL, insulin resistance, visceral fat, and even things like pregnancy complications or hot flashes can all be early signals, not just for heart disease, but for brain health down the line. Another important takeaway is how much nuance there is. Things like HDL being good cholesterol or Alzheimer's being type 3 diabetes, those are oversimplifications. The real picture is more complex, and that's why it's so important to look at your full set of biomarkers, not just one number. And then there's the idea of agency. Even with genetic risk, like ApoE4 gene, this is not deterministic. There is so much within our control, especially when it comes to how we support vascular health and metabolic health over time. And finally, something that really stood out for me, this idea that we need to be active participants in our healthcare. Understanding our numbers, asking for the right tests, and treating your relationship with your provider as a partnership is not optional. It's essential.
I agree. I think Barbie does a beautiful job of helping people partner with their healthcare professionals, getting the care that they need. And she's also going to be giving us one of her guides from her Substack, The Synapse, about exactly how to do that, some tips about that, as well as a guide for tracking all these biomarkers we've been talking about. So
Yeah,
what can
it's hard. I have gotten resistance from my healthcare professionals about giving me these tests and following them over time. And it's very frustrating for women. I think we're often told, oh, it's fine, you're fine. You really have to be an advocate.
And that starts with understanding why you need these tests, what they're for, and how they fit in the big picture. So
Hmm.
Barbie is just a wealth of information when it comes to that. So what can you actually do with all of this information? I would say first, know your numbers, not just your standard lipid panel, but ask about ApoB, lipoprotein A, fasting insulin, and markers for inflammation like high sensitivity C-reactive protein and homocysteine. These give you a much clearer picture of what's happening beneath the surface. Second, prioritize your cardiometabolic health early. This means supporting healthy blood sugar, keeping LDL and ApoB in a healthy range, and paying attention to blood pressure. These are not just heart metrics, these are brain health metrics. Third, build habits that support metabolic resilience. Regular movement, especially a combination of cardiovascular exercise and strength training, along with a nutrient dense, fiber rich, mostly whole food diet. Fourth, don't ignore signals. Things like pregnancy complications, increasing abdominal fat, poor sleep, or frequent hot flashes could all be clues that your system is under stress. And finally, advocate for yourself. If you're not getting the answers or the testing that you need, ask, push a little, find a provider who will partner with you in prevention, not just treatment. Because the goal here isn't perfection, it's direction, small, consistent choices that support your brain over decades. And Jenny, another thing that I just love that Barbie was talking to us about is the way she does exercise snacks whenever she has
Yeah.
to go to the bathroom. She'll do a bunch of squats and push-ups. Don't you love
Yeah.
that?
That's great. I'm totally going to steal that.
Me too.
It's hard when you're working all day or, you just sit and sit and sit. And it's great to have reminders.
Absolutely. And I also like how she is committed to a walking program,
Hmm.
an hour in the morning, hour at night. And anyone can do that for as many amount of minutes that you can. It's really useful. And also how she likes to take herself for a walk and she puts her AirPods in and she just talks through things with herself. I just love that.
And I do the same thing. I've never told anybody, but I do that too. It's like having your own little therapist on your walk.
Well, I'm definitely doing that. I just usually talk to my dog, but I'm gonna start talking to myself too. Well, this was fantastic. Thanks, Jenny. I love your takeaways. And it was just incredible to get to speak with Barbie for that long.
Yeah, she's amazing.
I write about brain healthy eating every week. I talk about it on this podcast, and I wrote the book literally on brain healthy cooking. But it wasn't until I went through the Better Brain program that I made important changes to what I was doing day to day, like a B vitamin absorption issue I never knew I had, and a slight uptick in my cholesterol, to name a few. Now I'm already starting to see improvement in my brain health biomarkers, thanks to our founding sponsor, Better Brain. They provide a science-backed brain health lab panel and expert coaching. Most people pay $0 out of pocket for these sessions. Check it out at betterbrain.com/Annie and build your personalized brain health action plan covered by insurance. I'd also like to thank NeuroReserve for being a founding sponsor for this podcast. Check out their brain health nutritional products like Relevate, Brain Health Kitchen Extra Virgin Olive Oil, and Revanta Creatine. I've known the NeuroReserve team for many years, and I also use their products as part of my own brain health care routine. So go on over to neuroreserve.com and use code BHK podcast for 10% off. The Brain Health Kitchen podcast is for educational and informational purposes only. The content shared on this podcast, including conversations with guests, is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The opinions expressed by guests are their own and do not necessarily reflect the views of the Brain Health Kitchen podcast or its hosts.